Hi, I'm Felice Lapar. This is going to be the session on breast, colon, and lung cancers for the Geriatric and Palliative Medicine Board Review. I am a physician. I am a hematologist, a general hematologist and oncologist. I did a geriatrics fellowship before I did my oncology training, which was at Mount Sinai. And I'm board certified in geriatrics, but do practice general hematology and oncology. So no conflicts to disclose. The objectives of this presentation are to explore differences in cancer treatment for older individuals, to review current management of breast, colon, and lung cancer in older individuals, to discuss issues for primary care providers of patients with cancer, and to address timing of hospice. And hopefully some of these things will be helpful for you in general practice or in these areas. In terms of the board exam, it's difficult to predict the oncology content of the board exam if you're taking this as board prep. And older patients are often underrepresented in clinical trials, so a lot of what we will discuss will be general management. We'll do 3 cases with discussion questions. The first case is the longest. So case number 1, you assume the care of Ms. BC, a 72-year-old woman who has hypertension controlled with HCTZ and hyperlipidemia. She lives alone and is independent in her ADLs and IADLs. She babysits for her active 2-year-old grandson twice a week. You ask when her last mammogram was, and she says she cannot remember exactly, but probably about 5 years ago. You decide to proceed with a mammogram, which shows a mass in the right breast that is highly suspicious for cancer. She undergoes a core biopsy that shows invasive ductal carcinoma, ER positive, PR positive, and HER2 negative. On exam, you do not palpate any lymph nodes in the axilla. So where's additional information available for you? So in oncologists, we use something called NCCN guidelines, National Cancer Center Network guidelines. These are algorithms developed by consensus panels and used by oncologists. They are considered the standard of care. It's free to sign up if you want to see. Again, these are definitive. They have everything starting from diagnosis and staging to workup to treatment to surveillance. And there are, in addition to the algorithms, there are discussion sections if you want to just read more about something. There are also guidelines. There are guidelines for every kind of cancer. There are also supportive care guidelines, which might be helpful in palliative care. And there's also an older adult guideline. And then cancer.gov has some summaries for patients. So should she have a mastectomy or breast-conserving surgery? Depends on a number of factors, including the size of the tumor, the size of the breast, patient choice, possibly whether she is willing and able to have radiation. We'll talk about that in a minute. An ability to tolerate surgery. And of course, we don't assume that older women don't care. Mostly, we assume we're going to start with breast-conserving surgery. So what are the options for axillary evaluation? So sentinel lymph node biopsy is really the standard. That's where the surgeon goes in and injects into the breast a blue dye or radioactive tracer. And wherever the lymph nodes light up, they remove those lymph nodes. If the lymph node is positive, there may or may not need a full dissection. We're really moving away from that. Axillary dissection, the types you used to see from many, many years ago, where there were 20 lymph nodes removed, those are pretty rare. There is a risk of lymphedema if many lymph nodes are removed, and it's really not usually done without a sentinel lymph node biopsy. And sometimes we'll use a clinical exam, especially in older or frail patients. The staging is not precise, but we may decide that it's not going to change management anyway. So Ms. BC undergoes breast-conserving surgery. Pathology reveals a 1.2 centimeter invasive ductal carcinoma coming ER, and it's ER and PR positive and HER2 negative, and sentinel lymph node biopsy is negative. So ER is the estrogen receptor, PR is progesterone receptor. Those are the hormonal receptors and the ones that tell us whether the tumor is going to respond to hormones. And HER2 is a marker for aggressive disease, but it does have specific treatments. So the stage of the breast cancer. So this is the general staging schema for solid tumors. Solid tumors are generally staged by T and M classification. So the T stage is the local stage, how large or deep it is. N is the number and location of lymph nodes involved. And M is whether metastases are present. Generally, M0 means no metastases are present, versus M1 means metastases are present. The staging can be clinical, For example, on imaging, we might say it's a clinical T2 based on the size of the tumor, or it can be pathologic, which would be by biopsy. We might say PN1, again, because it was biopsied. And again, this is the general schema for solid tumors. This is not applied to, quote, liquid tumors, which are things like lymphomas, leukemias, and multiple myeloma. So the TNM staging is then grouped into stages by each tumor. Stage 1 is local or early disease, usually node negative. Stage 2 has more local involvement, and stage 3 is locally advanced, and stage 4 is metastatic disease. And we'll talk about in a little bit why there's a cut point at metastatic disease. So for breast cancer, the stage specifically for breast cancer, stage 1, again, small tumors, less than 2 centimeters and node negative, and there is a difference between a 1 centimeter and a 2 centimeter tumor. Stage 2 is node negative, 2 to 5 centimeters, or node positive with early nodes, and 1. Stage 3 is locally advanced, and stage 4 is metastatic. And breast cancer also has prognostic staging, which includes ER, PR, and HER2 as well. So additional staging workup, again, NCCN guidelines can tell us about this. We do CBC and LFTs as well as complete metabolic panel. We do want to see things like LFTs and the alphas. In terms of imaging, really a lot of imaging is not recommended in early stages. We might consider an abdominal CT or MRI, bone scan, and chest imaging. But again, these are really for higher stages, localized symptoms, specific lab abnormalities, or the way it is in the guidelines now, someone you think might be at higher risk for whatever clinical reason you have to think that. Again, generally they recommend against routine imaging for early stage disease. And there may also be as part of the staging a question of breast MRI. So the order of further treatments, if we're doing all of these, which we may not be, would be chemo, then radiation, then hormonal treatment. In some cases, we use neoadjuvant treatment before surgery. So in terms of defining the terms, this might be one of the most important slides in this whole presentation. The definition of adjuvant and neoadjuvant. So oncologists use these all the time. It really gets to what our intentions are in terms of treatment, and important to know, especially if you're involved in discussing goals of care. So adjuvant is something that we do after curative resection to decrease the risk of recurrence. It can be local, such as radiation therapy, systemic, chemo, hormonal therapy, targeted agents, or even immunotherapy now. In the adjuvant setting, there's no evidence of cancer on the staging study, so there's nothing to follow. And treatment's given for a defined amount of time. We use a study that says give 4 cycles of some chemotherapy, and patients did better, and we do exactly what they did in the study. This is a different goal from chemo for metastatic disease, which is considered incurable. Neoadjuvant is what we do before curative resection. We might do it to reduce the size to make something more resectable. There are certain tumors where we do use it frequently. One of them, for example, is rectal cancer, where we're trying to shrink the tumor so that the surgeon can have an easier time working in a very small space. It can be used in breast cancer as well, and again, some other cancers as well. Cure is not scientifically defined. It basically means that the cancer is gone and will not recur. Oncologists are pretty hesitant to tell people that they're cured, though they will use it often as what they're thinking of for in terms of the goals of care. Oncologists often use NED, no evidence of disease. In terms of, again, we can't define when somebody is cured. We can tell from the Kaplan-Meier survival curves. Those are those stepped survival curves. When the curve flattens, if people have not, it means that people have not recurred beyond that time. And then we think that the risk of recurrence beyond that time is not going to be high. And palliative, oncologists sometimes use that term a little bit differently than other physicians do. Sometimes they'll mean they're using it just for treatment of metastatic or incurable disease, not necessarily in the way that other people might use it to talk about treating for symptoms. So should she have radiation therapy? So the standard in breast cancer for years has been lumpectomy followed by radiation because it's equal to mastectomy for local recurrence. There's no survival benefit in individual studies, question of a small survival benefit overall. You can consider, per guidelines, omitting radiations in patients over 65 in breast cancer with ER-positive stage 1 disease, who are receiving adjuvant endocrine therapy. Originally, the study had been done, it was over 70. Now they're broadening that a little bit. But again, sort of moving a little bit away from radiation. It does have to be patients who can take an aromatase inhibitor or adjuvant hormonal therapy. So if you think that there may be some reason that they can't have it, and we're going to discuss those in a minute, would be more reason to do the radiation. So chemotherapy is really resolved for patients who, in chemotherapy, resolved for patients with higher risk. We're going to talk about that in a minute. Older patients may be at higher risk for toxicities for all the reasons that affect older patients, including changes in renal and liver function, pharmacokinetics, drug interactions. And adjuvant treatments have less benefit with decreasing life expectancy. Remember, we just said adjuvant treatments are essentially preventive treatments. They're secondary or tertiary prevention, depending how you define that. And so you're going to have to balance the risk of avoiding the cancer coming back versus the risk of a treatment in someone who is older. Geriatric assessment can help, but we need to make individual decisions based on life expectancy, comorbidities and function, and patient preferences. So really, more even than other patients, the discussions really have to start with what is the goal, and then we go from there. So in terms of chemotherapy for breast cancer, specifically for ER-positive disease, there's a question of whether to add chemo. The aromatase inhibitors or tamoxifen, the antiestrogens, are really the ones doing the work of treating the cancer. We run something called an Oncotype DX score. It's a recurrence score derived from a 21 gene panel on the tumor. It sees what genes are upregulated, and the score gives information on who benefits from adding chemotherapy to the hormonal therapy. It's established for ER-positive node-negative disease, and also approved in postmenopausal patients with low node-positive disease. So with node-negative ER-positive disease with a low-risk oncotype, we would not give in chemotherapy. In older patients, chemo is generally given for HER2-positive disease with a trastuzumab-containing regimen, or triple-negative disease, i.e. ER, PR, and HER2 are all negative. Those are both more aggressive tumors. And again, it's an individual decision in an older patient with ER-positive node-positive disease or ER-positive disease with a high-risk oncotype. So in terms of who gets adjuvant chemotherapy, the ER-positive node-negative with a low-risk oncotype do not. And then the others, we're having a discussion again, and that's all in the context of age, performance status, and tumor size. So the Oncotype DX confirms a low risk of recurrence after discussions with the medical oncologist. You all agree that she will not receive chemo. She decides to forego radiation therapy as well because she'll be starting hormonal therapy. So the options for hormonal treatment: an aromatase inhibitor for 5 years. Now there's some 10-year data. We're going to talk about that in a minute. And then tamoxifen, and some combination of tamoxifen and aromatase inhibitors for 5 to 10 years. The first choice is generally an aromatase inhibitor if they are postmenopausal. So the aromatase inhibitors that are available are letrozole, anastrozole, and exemestane. In terms of the mechanism of the aromatase inhibitors, they work by inhibiting peripheral production of estrogen. It turns out that postmenopausal women still have some estrogen. It is manufactured in the adrenal glands and then converted in the tissues to estrogen. So we're further depleting their estrogen, and it's the opposite of hormone replacement therapy. Patients must be postmenopausal because the ovaries produce too much estrogen for the aromatase inhibitors to work in premenopausal women. So again, this is not going to be a case in the older patients, and actually if they're over 60, more of a younger patient issue in the younger patients. So the toxicities of the aromatase inhibitors versus tamoxifen, again, the aromatase inhibitors are depleting estrogen, so the things that you would think would be toxicities from that are the ones that we think of. And that's going to be the main issue, is really going to be osteoporosis, and obviously something that geriatricians think about all the time. Fractures, hot flashes, musculoskeletal disorders, question of effect on lipids. Tamoxifen is what we call a SERM, selective estrogen receptor modulator. It acts like an estrogen agonist in certain tissues and an antagonist in other tissues. So the tissues where it's working like an estrogen agonist, with estrogenic properties, it can cause problems that you might expect, including vaginal bleeding and discharge, endometrial cancer, ischemic strokes, and venous thrombosis. And those risks do go up with age. So it is something, again, one of the reasons why we lean against that in older patients. Other issues with tamoxifen, some patients may not metabolize well to active the metabolite, and they may not get all the benefits. And hot flashes are good because they indicate drug metabolism, and some SSRIs interfere with metabolism. Again, not generally a first choice at this point. So how long to give the aromatase inhibitor? It's generally been 5 years. There has been some data extending to 10 years, and there is some testing to determine risk of late recurrence. We might consider it if more lymph nodes are involved. We need to balance that against bone health. And it really is sort of a discussion of involving a lot of issues. So if you are in general practice, you have a patient you're just refilling their anastrozole or whatever their aromatase inhibitor is, they haven't been to the medical oncologist for a while, it's probably worth sending them back to the medical oncologist specifically to discuss if it is reasonable to stop or what the timing will be for stopping the aromatase inhibitor. So Ms. BC is given 5 years of anastrozole and her bone density is noted to drop. So options for bone health, sort of the usual ones, calcium and vitamin D and bisphosphonates and denosumab. And that's for breast cancer. It has a specific indication for breast cancer receiving an adjuvant AI at high risk of fractures. The dose is the usual osteoporosis dose, 60 milligrams every 6 months. Just of note with that, it's a general issue with this drug, but you cannot stop acutely due to vertebral fracture risk. So, and they may need a bisphosphonate at the end of treatment. So again, if you have a patient who maybe was getting it from denosumab from their oncologist, they sort of stopped seeing their oncologist and nobody noticed they had not gotten their denosumab, send them back and make sure we figure out what we're doing at the end of treatment with denosumab. So in older patients with breast cancer, often there's really only minimal treatment if they're ER positive, and that's often the usual scenario in older patients. So many patients have low risk node negative ER positive disease. They may not need imaging, radiation, or chemo. And surgery may be a sentinel lymph node and a lumpectomy, and then treatment with 5 to 10 years of an aromatase inhibitor. So really, again, some surgery and a pill, and it may not be burdensome treatment. So next we're talking about surveillance, trying to figure out if the cancer is going to come back or if it is coming back. So in general, for surveillance in cancers that are not metastatic, we have to see what do we need to do to see if they're coming back. Again, this is dictated by NCCN guidelines. In breast cancer, like other cancers, we're looking for recurrence, but with breast cancer specifically, not with other cancers, the disease is likely incurable if it's metastatic, so it may not help to find it earlier. I know that that's not intuitive, but that's what we know about breast cancer. So recommended surveillance, the interval history and physical 1 to 4 times a year, and then for 5 years, then annually, mammogram yearly. If they recently had breast cancer, you want to order it as a diagnostic so that they get additional views. That'll depend on your institution for how long you order it as a diagnostic. You want to do bone health monitoring on the aromatase inhibitors. Tumor markers are not officially recommended, and there's no routine imaging. So we don't do blood tests. We don't do scans to see if it's coming back. We should encourage active lifestyle and achievement of ideal body weight. So for breast cancers, especially those ER-positive breast cancers, minimal surveillance is recommended, but because it can come back and even many years later, especially for ER-positive disease, we really want to work up any new symptoms aggressively. Back pain, headache, shortness of breath, cough, anything that seems unusual. If it would be, for example, just a new back pain in somebody that you wouldn't think much of it in someone who's older, if they have a history of breast cancer somewhere in their history, you do need to have at least in the back of your mind whether it could be breast cancer, and think about doing having a lower threshold for imaging. So 5 years after finishing a anastrozole, she's now 82 years old. She complains of mild pain in her left upper arm. She is still independent in her ADLs, but no longer drives or does her bills. X-ray confirms a lytic lesion, and bone scan shows several lesions in her arm, spine, and pelvis that are likely metastatic. CT reveals no visceral lesions. Biopsy confirms recurrent breast cancer, ER positive. So Ms. BC's daughter is very upset by the news and tells you that she wants to get her in the best care and has looked her into enrolling her in hospice. How do you respond? So metastatic breast cancer can have a very variable course with some long-term survivors. ER positive bone-only disease may be more favorable. However, failure after adjuvant treatment may be worse. There are many options for hormonal therapy and chemo still available, and her survival may be far greater than 6 months, so she does not seem like she is ready for hospice now. So options for treatment for metastatic disease, hormonal agents are preferred in ER-positive disease if there is no temporal urgency, if it's not something there's any organ threatened. The aromatase inhibitors, tamoxifen, fulvestrant, which is an injection. There are whole classes of other drugs, something called CDK4/6 inhibitors, and others. And that's really sort of changed over the years as well. So we have a lot of options in that space. Chemo, we still do single agents and combination if visceral structures are threatened, but we do it less and less now in metastatic ER-positive breast cancer. So treatment for bone metastases. So, radiation, if there is imminent fracture or pain, consider ortho pinning a weight-bearing area if if there may be imminent fracture. Think about doing an MRI of the spine if you know there are any metastases or spine metastases. You really want to try to catch anything that might cause cord compression early. And then we have to use an osteoclast inhibitor. Zoledronic acid, which is a bisphosphonate, you can use it every 3 months in the setting, or monthly, depending on the setting. But the 3 months decreases complications. You do have to watch the creatinine, and for osteonecrosis of the jaw, so they do need dental clearance if possible. Pimidronate is another one, and they do need calcium and vitamin D supplementation. And then denosumab, again, a different trade name when it's given in this setting for bone metastases. It's a monthly sub-Q injection. Not clear if it's 120 milligrams every 4 weeks versus, remember, in the osteoporosis setting, it's 60 milligrams every 6 months, so a much higher dose. Not clear if we can do it a little less frequently. Also risk of osteonecrosis of the jaw, and they need the calcium and vitamin D. So next case, moving on. So Mr. CC is a 71-year-old attorney in good health who gets his first screening colonoscopy, which reveals an adenocarcinoma in the right colon. He undergoes resection, which reveals that the lesion is 2 centimeters, invades into the subserosa, and that 2 of 16 lymph nodes are positive for tumor. So staging workup. So is to determine if there are metastases prior to surgery. We do a CBC, chemistries, LFTs, possible, and definitely a CEA. So in this, we do have a tumor marker, especially for colon cancer. The CEA, we do want to get that before resection if possible, so we know if the tumor is producing CEA, and a CT of the chest, abdomen, and pelvis. If it is not metastatic, again, we are doing that imaging, unlike with breast cancer. We're going to do the resection and take lymph nodes with the colon, and you always want to get more lymph nodes. Hopefully they can get 14. So the stages, so 1 is superficial, node negative. 2 is a little deeper. It's a T3 or T4, but still node negative tumor. Stage 3 is node positive, and stage 4 is metastatic. Again, that cut point between the early stages 1 through 3 and metastatic disease. So in terms of which stages receive adjuvant treatment, 1 does not. Its resection is considered to be curative. 2 is controversial. Some high-risk patients benefit, and stage 3 do receive it. So adjuvant chemotherapy regimens, there are just a few that we use. 5-FU and leucovorin is sort of the backbone treatment for colon cancer. And then we add oxaliplatin. Again, this is a basic treatment. It's a 5-FU bolus, and then they require a port and a 46-hour infusion every 2 weeks. So they do have to have the port. The oxaliplatin, the main issue is that it causes neuropathy, sometimes acute neuropathy, but also chronic neuropathy and some cold intolerance. We can also do that instead of the 5-FU, the infusional 5-FU, we can use capecitabine for which is 5-FU. So in terms of capecitabine, that's an oral 5-FU analog. It's given twice a day for 14 days, then 1 week off for 6 months, or depending on what regimen we're using. Causes diarrhea and hand-foot syndrome. And there's a question of compliance with oral medications, but we're still seeing those patients frequently, and a question again of less contact with physicians. So those are sort of the really, especially the main adjuvant treatments, and really still backbone treatments for colon cancer. So in terms of adjuvant chemo for colon cancer, again, there might be less benefit and higher toxicity with age increases. As age increases, adjuvant chemotherapy is preventive, and we have to look at the individualized assessment of risks and benefits. So he decides to receive Folfox, but is bothered by neuropathy and switches to infusional 5-FU. They just dropped the Folfox. And so surveillance, again, we have to see. So we did chemotherapy, we gave adjuvant chemo, did surgery, we gave adjuvant chemotherapy, and now we have to see if the cancer is coming back. And again, NCCN guidelines will have specific recommendations for us. So we do a history and physical, a CEA every 3 to 6 months for 2 years, and then every 6 months for 5 years. And you also have to do CBC, LFTs, of course. The CEA, again, we talked about that as a tumor marker, and then you can detect resectable liver metastases, occasionally other metastases. This is different from breast cancer because if we find a resectable metastasis, we may still be able to render someone NED. So we are looking for those metastases early because there's something we can do about them. We do a CT chest, abdomen, pelvis annually for 5 years for stage 2 to 3. And then a colonoscopy 1 year initially, or every 3 to 6 months if it was obstructing preoperatively. And then in 1 year if advanced adenoma, 3 years if not, or 5 years. The candidate for intervention, again, this would be something that hopefully your GI doctors or your colorectal surgeons are helping you with as well. So Mr. CC recurs in 13 months with unresectable liver metastases. In terms of the treatment options, still have 5-FU, oxaliplatin, capecitabine. Again, those are backbone treatments that we wouldn't necessarily give them. It'd be a question what we would give if he recurred. Irinotecan is another basic medication for colon cancer. It can cause diarrhea. And then we have other classes of medicines that we use for colon cancer. Bevacizumab and newer analogs. So bevacizumab is an anti-VEGF, vascular endothelial growth factor antibody, and it affects tumor vasculature. We use it with cytotoxic chemotherapy, but because it is affecting the tumor vasculature, it has specific risks. And it's important to know about those, especially if you are in primary care and you're seeing a patient. So it can have hypertension, arterial thrombosis, so we have to be careful if there's coronary artery disease, proteinuria, GI perforation, GI bleeding, and wound healing issues. So we do need to be careful about any procedures. We really don't want to be doing any procedures if someone is getting bevacizumab or another drug that has anti-VEGF activity. And then other drugs, cetuximab or panitumumab, those are EGFR antibodies. They have allergic reactions and a rash, as well as diarrhea. There may be immunotherapy if they are MMR deficient. We're going to talk about the immunotherapy in a little bit. And there can be other targeted agents based on molecular testing. So survival with metastatic disease, and should he be on hospice? So for newly diagnosed metastatic disease, survival was initially 8 to 12 months with 5-FU, but now much longer with new chemo and other agents. It can be several years, and it may be worse, however, after adjuvant therapy, especially if it's a shorter interval. Again, it's going to depend on the age and performance status and all of those issues when you're making these decisions. So next case, Mr. LS is a 75-year-old male who has a chest x-ray during an ER visit for chest pain and is noted to have a 3-centimeter nodule in the right middle lobe. He has a 30-pack year smoking history, has lost 10 pounds in 3 months, has some dyspnea on exertion, excuse me, with walking 1 block, but is still relatively active and enjoys working in his garden. So what next? Again, we're going to look at NCCN guidelines to tell us what to do. We technically chest, abdomen, usually we do the pelvis CT with contrast to evaluate mediastinal lymph nodes, CBC chemistries, LFTs, and an LDH. And a PET CT. So a PET scan is a nuclear medicine scan. So a regular PET CT is fluorodeoxyglucose. It's radioactive glucose. It goes to areas of metabolic activity. We use it in lots of different places in oncology. Certain diseases more than others, depending if they're more likely to show up. Lung cancer is one of those places, and it can tell us whether there are mediastinal lymph nodes and or metastases. We do a brain MRI for higher stages because it can go to the brain. Possibly a bone scan if you haven't had a PET scan. And we do need to do staging of the mediastinum for lymph nodes, possibly a mediastinoscopy or bronchoscopy. Again, depends on the stage. So we might do a biopsy sometimes. In some cases, if it's an isolated lesion that's suspicious on CT and PET, sometimes they'll proceed directly to surgery with a lobectomy if the frozen section is positive. And sometimes there will be an EBUS, which is endobronchial ultrasound. And sometimes they can do an EBUS biopsy for the lymph nodes. So if it's non-small cell lung cancer, we do staging to determine nodal status and metastases. And based on the staging, there can be a combination of treatments for stage 1 and 2. Generally, lobectomy is considered to be the proper cancer surgery. We might need adjuvant chemotherapy, again, depending on the stage. In stage 3, there are a number of different permutations of stage 3. Chemo, possibly chemo, radiation, or surgery, depending on the clinical factors. And stage 4, remember stage 4 is metastatic disease. So that would just be systemic therapy generally. So in terms of those early stage patients, however, in some medically inoperable patients, patients who are considered to be high surgical risk or have comorbidities, or for whatever reason, or refusing surgery, for whatever reason, are not going to undergo surgery, for the very early stages, we might consider definitive radiation therapy, and for the slightly higher stages, not stage 4, but stage 3, possibly definitive chemoradiation if they're not going to give surgery, but they'll still have some treatment. So CT and PET reveal a mass in the left adrenal consistent with metastatic disease and multiple masses in the liver. Biopsy of a liver mass shows adenocarcinoma with stains consistent with lung argin. So what next? So we just have the imaging, we have to biopsy something. So this might be a little counterintuitive, but we want to try to biopsy the site that will confer the highest stage disease. So we're not going to biopsy the lung, even though we think it's the lung cancer. We're going to biopsy the liver. And then in the liver, they're going to, when the pathologist has the tissue, they're going to run a number of stains to confirm site of origin. So you can run things like, for example, TTF1 to confirm that it would be lung origin. And then you've both confirmed the primary and that they have metastatic disease, because we really do want pathologic confirmation of metastatic disease if we can get it. So performance status. So all of oncology really, we're always thinking about performance status, specifically in lung cancer, but really all of oncology in terms of what treatments we're doing. And generally we think of there's ECOG and Karnofsky performance status. ECOG is one of the ones that we use frequently. And there are five stages. So there is 5 scores. So 0 is fully active with no restriction. 1 is restricted in strenuous activity, but able to do lighter sedentary work. 2 is can do self-care, but no work, in bed for less than 50% of waking hours. 3 is limited self-care, in bed or chair for more than 50% of waking hours. 4 is disabled, completely disabled and bedbound. And 5 is dead. So there are groupings here. So 0 and 1 are considered in one group. 2 is sort of its own group when we're talking about performance status, and 3 or 4 are their own group. So this was initially developed more because of the correlation with tumor burden with performance status. It's not always fully relevant to older patients. They may have, for example, problems with their knees, terrible osteoarthritis in their knees, and that may be limiting their performance status rather than an issue with the tumor or other issues. So you do have to think about this. Also, they may not be working anyway, so you do have to interpret this a little bit carefully, but generally still helpful to have some idea of performance status when we're thinking about treatments. So usual treatment for advanced lung cancer. So really right now we do something called NGS, next generation sequencing, or panels, where we're going to look for multiple molecular targets, and super important in lung cancer. And so the testing can be on the tissue. Hopefully, if we have a tissue biopsy, actually, we need that for the PD-L1 status. But we can also do liquid biopsies, which are blood tests that will sometimes pick up, if there are enough cancer cells in the blood, it will pick up mutations, and we can use that for treatment. And we sometimes will do both, and sometimes you can pick up different things on those testing. So we want to see if there are any target agents. If there are no targets, we consider immunotherapy and or chemotherapy. So do older patients benefit? So there was sort of this older, a number of years ago, there was a whole literature that developed on chemotherapy before we had immunotherapy on older patients. And the outcome was that single agents might benefit older patients even significantly. Older, even though you would think that there was risk to it, but the issue is that the risk of the cancer is probably worse than the disease. And now we might use immunotherapy, which really is a game changer. So molecular testing, again, it's a panel. It's a multi-gene panel that we're looking for actionable mutations. One of the most common is something called EGFR, mutant non-small cell lung cancer. It might be more common in non-smokers, and we can give a lot of these targets have pills that we can give, TKI inhibitors or other pills that we can give for the EGFR mutant cancers. The oral agents often have rash and diarrhea. Those are pretty common. You do have to watch for interstitial lung disease. Other targeted agents might have specific side effects, including some of them have anti-VEGF effects. So remember, we talked about high blood pressure, the perforation, GI bleeding, and wound healing issues are if you have something with those. So you do really, for each agent, need to actually look at the PI if you can and see what are the issues, or hopefully you have a medical oncologist who is helping you with that. So other drugs for metastatic disease, again, bevacizumab is one of the drugs. We just talked about those side effects again, and this is for non-squamous with no brain metastases. And something for adenocarcinomas is pemetrexed. It requires B12 and folate supplementation. It's well tolerated with easy administration. You do have to use caution with NSAIDs. Anything that's going to change the renal clearance. So immunotherapy. So let's talk about that. So how does immunotherapy work in oncology? So it turns out that the body has developed a good way of looking for foreign invaders. That was developed to look for bacteria and viruses, and the body can come up with an elegant molecularly targeted solution for those pretty quickly. That's what the immune system has done. And the immune system is is there to recognize self versus non-self. In cancers, the cancers develop ways to evade the immune system. And so the immunotherapy is there to unleash when we talk about these drugs, they unleash the immune system and let the immune system attack the cancer. These have really revolutionized oncology. We can look at things like PD-L1 percentage in lung cancer, and we might use immunotherapy alone or in combination with chemotherapy. There are a number of drugs, pembrolizumab, atezolizumab, nivolumab, ipilimumab, and others are always other immunotherapy drugs coming online. The main issue, remember, we're unleashing the immune system to let it attack the cancer. But so you're going to get autoimmune side effects, immune side effects, which are really the issue with immunotherapy, then occur in any organ. And so we need to watch carefully and treat with steroids, and anything that seems really unusual, you have to think, could this be immunotherapy? Things you wouldn't even think about. Someone comes in with new AKI, with new renal failure, you always have to think, well, is this because they're dry or is this an immune side effect? Again, any organ, anything unusual. They can have dramatic responses to immunotherapy, sometimes for a long time, sometimes even after stopping, people will have responses. And again, we don't like to call it cure, but it's really remarkable. The timing is not like it is with chemotherapy, where it really only works while you're using the drug. And sometimes we can use it in patients who are not candidates for chemotherapy, especially in older patients. But again, that's going to be a discussion. So, survival with metastatic disease and when are patients ready for hospice? So for non-small cell lung cancer, traditionally survival was usually less than 1 year with metastatic disease. However, immunotherapy, like we said, can have dramatic responses, sometimes for a long time. And performance status matters. Again, if they have performance status 3 and 4, hospice may be reasonable. So it's going to be an individualized discussion, especially with immunotherapy, about what are we doing? Do we want to try? These can be difficult issues. So palliative care, there was a reason to do early palliative care. There was a study in 2010 that showed that early palliative care in metastatic non-small cell lung cancer improves quality of life. And adjuvant chemotherapy, this is another, all of the cancers we're talking about today might benefit from adjuvant chemotherapy. There are some patients who do benefit from adjuvant chemotherapy and we're talking about now early lung cancer that's been resected or treated. So in terms of immunotherapy and other cancers, again, we just talked about it. It's been evaluated in nearly every cancer. It may correlate with high tumor mutational burden, right? So things that are associated with smoking and sun, there may be a lot of what we call neoantigens, new molecules that the body doesn't recognize as self. And so it's going to try to attack those if it can get unleashed, we can stop the cancer from hiding from the immune system. It was first established in melanoma, obviously associated with sun issues, but there are indications in multiple cancers. When you look at the package inserts for these drugs, they go on for pages and pages and pages. And there's also an indication for MSI high cancers, which is a molecular abnormality. Some of these indications are actually tumor agnostic. Side effects of immunotherapy, again, they can cause autoimmune side effects in almost any organ. So you have to have a low threshold to evaluate and consider new symptoms and lab abnormalities. Anything that seems unusual, you really have to consider. If somebody's having diarrhea, that's a specific issue that it's a sort of a high frequency issue. You have to look at rashes, LFT abnormalities, but really anything. And remember that immunotherapy is really the opposite of what rheumatologists are doing. When in oncology, we're unleashing the immune system, we're letting it attack a tumor, versus the rheumatologists are suppressing the immune system. The overall immune side effect rate is unclear. It's probably 20%, at least 20%, sometimes even up to 40%. When we don't really get numbers the way just studies are done there for individual toxicities, but that seems to be about what it is. So you do have to counsel patients on that. Treatment, because this is an enhanced immune system, is steroids and prednisone are the mainstay of treatment, sometimes other immunosuppression, but that's the mainstay of treatment. There is one little exception, which is hypothyroidism, that you can treat through it and add levothyroxine. And we do have to be careful if patients are on steroids for other reasons. Let's say they have COPD and they're on a lot of steroids, we do have to be careful about using immunotherapy. It may not work if they're on a certain dose, so higher dose of steroids. So palliative care and goals of care. So again, immunotherapy really changes the calculus because it's not predictable. And somebody who might have a short who might have otherwise had a very short survival. When we give them immunotherapy, maybe they have a chance at a long-term response. And so again, these can be really difficult discussions, especially if you're on the palliative care side and having these goals of care discussions. So is chemo required for older patients with metastatic disease? Again, chemo is not curative. We need a discussion regarding goals and preferences and inclusion of the family. Some older patients may choose not to have chemo. I'm sure a lot of you have seen that. And the patients and family may need reassurance that that's okay. Again, immunotherapy sometimes makes it an issue in terms of changing the calculus a bit. So medical oncology referral, make sure your medical oncologists are involved in these decisions because it's really always a changing landscape. Older patients with cancer are less likely than younger patients to be referred to medical oncology based on some older data. Hopefully that's changing, but again, it may not be. And cancer treatments can change quickly. And again, there may be someone who's older who you don't think is a candidate for any treatment, but it's at least worth a discussion. So bottom lines, cancer is common in the elderly. Elderly patients have been underrepresented in oncology studies. It's unclear how much the literature can be extrapolated, and we approach each patient individually, considering function, comorbidities, life expectancy, patient preferences when making decisions. So some questions here. So adjuvant therapy, A, is used to shrink tumors before resection. B, decreases the risk of cancer recurrence after resection. C is used to palliate symptoms after cancer has spread, or D only refers to chemotherapy. And just take a sec there. And so the answer is B, decreases the risk of cancer recurrence after resection. Remember, we said there can be different types of adjuvant therapy, but generally adjuvant therapy is something we're doing to try to prevent the cancer from coming back. Stage 4 disease in a solid tumor. A is generally considered incurable. B is always an indication for hospice. C has a survival less than 1 year, or D can only be treated with chemotherapy. And that has been the general thought, was that stage 4 disease is considered incurable. But again, as we just said, a little bit of a question there with immunotherapy about long-term responses. So thank you very much for your attention.